Okay. Hello, everyone. We're going to go ahead and get started. My name's Akash. I'm one of the chief residents, mostly at the VA. Welcome to all of our applicants who are joining us virtually. We're thankful that you chose to interview with us, and I hope you're enjoying the interview day so far. CPC is our weekly Friday noon conference. That's a long-standing tradition here at WashU, where we present a difficult case to one of our faculty to understand how they reason through clinical problems. Today, our case is a 37-year-old man with a history of diet-controlled diabetes who presents with syncope. And our expert clinician is Dr. Farhan Katchi, an associate professor in the Division of Cardiology, known for his outstanding teaching abilities and expertise in cardiac imaging. And Dr. Katchi was kind enough to send me some introductory slides that he will walk through for us before we get started with the case.
Thank you. Thanks for that introduction. Thanks for having me. I know I'm starting the slide with born in Portugal. I'll get to that in a second. But before I talk about my own timeline, actually, let's talk about the timeline, and I'll fit into why this invitation was so important to me and how it's very meaningful for me to be up here when I started sitting where you are as a medical student back in the day. So I was born in Portugal. Our whole family, me and my siblings were born there. I moved to the States in the 90s when I was about 10 years old. Grew up in Houston, went to Rice University, got a BA in biochemistry, then came here for med school, finished med school in 2011, became an internal medicine resident, and got to be trained by and taught by some of the best minds in medicine at that time, or even now. Some of my mentors then are still here today, come to these conferences. So it's just so odd for me to be here after being taught by some of the best mentors I could have ever hoped for. I went ahead and stayed as a hospitalist, worked with some fine hospitalists that are still here today as well. Had a great experience during that year. Made maybe the mistake of applying for cardiology fellowship at the beginning of my hospitalist year and ended up going to Cornell in New York City. I say that because I actually loved being a hospitalist. I loved putting my hat on as a general a practitioner, looking at every single organ system, solving problems on a day-to-day basis. And had I applied even a year later, maybe I wouldn't have done that. I probably would have loved just staying as a hospitalist at that time under Mark Tolke and others. But I did go to Cornell and actually ended up being one of the best things that ever happened because I love cardiology too. And I'll try to explain some of the reasons why later. Finished my fellowship in 2018. My wife, who was an MD PhD, she ended up matching at UPMC for oncology fellowship. So that took us to Pittsburgh, where I took a job as an assistant professor at Allegheny General Hospital with Drexel University. And then when she finished her fellowship, we came back to WashU because it was sort of a no-brainer. We have friends here. We know the institution. We know the caliber. It has awesome cardiology, awesome radiology. And for me, that was perfect. And here we are now. So we spent a long time in St. Louis, even though we've moved around since that time. So we spent 8 years in St. Louis from 2007 to 2015. We went to New York, which was awesome, Pittsburgh, and came back to St. Louis. And here we are now. I was in those seats as a student, and this was by far the best case conference that I attended. And I came all through residency as a hospitalist, and I still come now. I actually blocked off my clinic over noon hour. Don't tell my chief that, to be able to come make it to these conferences, because I still learn a lot every single time I come here. And so I was honored to be asked to do it. I actually didn't want to do it for several years because I didn't feel like I would rise to the occasion. But I finally relented and said, why not just come to this conference? So when I was given the prompt, I did get a little bit nervous because syncope in a young person can have a vast differential, especially in CPC. The most common thing in the real world outside of CPC is probably very simple, but when you come to CPC, it kind of opens the door for almost everything. And so we'll kind of run through what my initial thoughts would be and what I'm going to look for on the EKG, on the history, on the review of systems and the labs, and some of the more advanced imaging if we get there. And I said, how do I sort of organize this in a way that's easy to understand? Well, I just got asked to be the editor for the cardiology consult, subspecialty consult for the WashU manual. So I said, maybe I should start there. And so I looked at the book, and there's a whole chapter on the approach to syncope. And it turns out this particular publisher works with this osmosis from Elsevier to make videos, because nowadays people don't read. They usually watch 10 to 60-second clips on TikTok and learn. So Osmosis kind of took that and said, let's make 10-minute videos on these lessons. And they reference the cardiology manual, the WashU manual heavily. So I'm going to show you through what they have made pictorially, how we think about this on the clinical side. So I start with what is syncope? Is Akash sending me a real syncope presentation, or is that just something someone used in a chart and it's not really actually syncope? So the way you define it, it's a sudden transient loss of consciousness due to decreased cerebral perfusion. It's very general. Many things can cause decreased cerebral perfusion. So how do we categorize that in clinical practice? Well, the first thing you do if you see them in the ER or on firm or even your outpatient setting, are they stable or are they unstable? If they're stable, you have a lot of time to sort of figure things out. If they're unstable, well, it's all the ABCs, right? You stabilize their airway, breathing, circulation, get IV access, call the ACT team in your clinic if you have to, or have the ER staff sort of focus more aggressively on their unstable vital signs with all the basic things that you need. I assume because we're talking about CPC, it's going to be a longitudinal case. They're not going to be acutely unstable. I hope not, at least in the beginning stages of it. Once they're stabilized, you can take a focused history and physical. And most of your diagnosis will be filtered and refined just based on history and ECG alone. They called me to talk about a lot of advanced imaging, but most of syncopal cases you can really well categorize and define just based on EKG and history and physical alone. So go back to your history and physical because that will really suss out what your higher likelihood and low likelihood diagnoses can be. So if they're stable, what you want to look for in the history is how long was their loss of consciousness? Was it less than a minute? Was it 15 minutes? What's their postural tone? What are some triggers by history? Did they tell you that they were changing body positions? They were dehydrated. They just started a new diuretic. They were exerting themselves on a treadmill. They just found out that that their mother had breast cancer or something. Was there a strong emotional reaction? Were they defecating, urinating, or coughing? All these things can point you in a certain direction for syncope. Were there prodromal symptoms or were there no prodromal symptoms? That can really help refine what the etiology of the syncope can be. And then what's the physical exam showing you? If they just syncopize in front of you, are they having non-rhythmic muscle twitching? Are they having some sort of myoclonic jerks or any other posturing of any kind that could suggest a particular diagnosis? And then once you put all this together, you can say, okay, well, maybe there was syncope because it was sudden, it was transient, and there was evidence of decreased cerebral perfusion. And another thing in your mind when you're first assessing the patient, you want to rule out some of these mimickers of syncope. And what that could be, it could be seizures, or it could be a psychogenic pseudosyncope, or it could just be as simple as they're just hypoglycemic right in front of you, where the symptoms and presentation can be very similar. So very simply, you can check a blood glucose. And some easy differentiators between true syncope and seizures and psychogenic syncope would be that if you have myoclonic jerks, which can be very common with actual syncope, the difference is that with seizures, you get rhythmic activity and you have a post-ictal state. You don't often get a long post-ictal state with true transient syncope. And a psychogenic pseudosyncope can look exactly like syncope, except they have a complete normal exam, normal EKG, and they have a history of panic disorder, anxiety, and some sort of other supratentorial diagnosis. So once you've landed on syncope, you want to categorize, is it reflex-mediated syncope, is it cardiogenic, neurogenic, or orthostatic? Those are the four main categories of syncope that you can have. The most common being reflex-mediated syncope. And what does that mean? There's three different categories within reflex-mediated syncope. There's the vasovagal syncope, situational syncope, or carotid sinus syndrome. And each of those has a distinct sort of history and physical phenotype that we'll discuss in a minute. If you think it's cardiogenic, then think about structural heart disease, vascular diseases, and arrhythmias as the three biggest categories that cause cardiac syncope. If you have orthostatic hypotension, that can be diagnosed at the bedside with an orthostatic provocation, tilt table testing, et cetera. And if you have neurologic syncope, there's this different sort of flavor to how that's presented, and we'll go through that very quickly. Since this is the most common, this is going to be the slide that comes first, reflex-mediated syncope. So if I was seeing someone in an outpatient or inpatient setting, I would try to suss out if it's reflex-mediated syncope. You get sympathetic surge, and as a reflex to that, your parasympathetic tone goes up dramatically. You get increased vagal tone, and in that, you can either get a low heart rate response or a vasoplegic response where your blood vessels can't keep up the vascular tone to maintain perfusion. So it's either heart rate driven, cardioinhibitory, or it's vasodepressor, which would be vascular tone mediated. And this type of reflex-mediated syncope comes in vasovagal, situational, or carotid sinus syndrome, as you see at the bottom. And you can have clear triggers. So if you're having a huge emotional surge, you get more vasovagal syncope. If you're getting a blood draw as a med student, two med students in our class had vasovagal syncope from just having their own blood draw. And if you happen to have it associated with coughing, urination, defecation, that's more situational syncope. Some patients get really sensitive receptors in their, around their carotids, and they can have, if they're wearing a seatbelt and it rubs in their carotid a certain way, you can have syncope from that. You can have excessive stimulation of the or trauma to the neck in that area. Shaving, things like that can elicit a carotid sinus syndrome. But this will be very prodromal. It'll be more gradual as opposed to cardiac syncope that can be sudden, give you no warning and you go down. Here they'll get sweats, they'll get diaphoretic, they'll get clammy in their skin, and they'll get some sort of warning, so they'll be able to sit down and stabilize themselves instead of just injuring themselves as they would with some other form of syncope. So for orthostatic syncope, just remember that the true definition of orthostatic hypotension, you have to have them laying down for 5 minutes, check their blood pressure, have them sit up, wait 3 minutes, which we don't often have. That's 8 minutes of a 15-minute outpatient visit. So you can imagine how often that's done correctly. So you stand up for wait 3 minutes, then check the blood pressure again. If you get a drop in your systolic blood pressure by more than 20, diastolic blood pressure more than 10, then that is the blood pressure diagnosis for orthostatic hypotension. But you have to remember also you have to have an increase in your heart rate by more than 10 beats per minute as a compensatory rise in your heart rate to suggest that your heart rate response is appropriate for that orthostatic change. And if you don't have that, there might be some autonomic dysfunction that's also at play. It's more suspected if you're on diuretics, new vasodilators, anticholinergics, and especially in diabetics or Parkinson's disease. And I highlight diabetic because this patient's diabetic with diet-controlled diabetes. Neurologic syncope, if you get the 4 Ds, dizziness, double vision, diplopia, dysarthria, and got the 4th D. But if you get neurologic findings that suggest there's something more than what we've just discussed before, think more neurologic, ataxia, nystagmus, focal motor or sensory findings should make you think more towards a neurologic finding, usually a brainstem or posterior stroke type etiology. And so you can think about brain imaging more urgently than you would for someone else that's just coming in with typical reflex-mediated syncope. So I want to end with just talking about cardiogenic syncope, because I hope that's what this case is since I'm a cardiologist. And what I'm going to be hoping to hear is, did you have chest pain around the time that you felt you had syncope? Shortness of breath, palpitations, exerting yourself. Supine syncope is very specific from if you look at the literature and you look at all the syncope that comes into the ED, if they complain of supine syncope, think of cardiogenic off the bat. If they have a history of cardiac disease, many people in the family that had similar presentations, if they have an abnormal echo history, someone told them they had an abnormal EKG in the past, think more likely to have cardiogenic syncope. For the physical exam, if they have an irregular heart rhythm, if they have a murmur, an S3 or S4 gallop, S3 suggesting more of a volume overload LV dysfunction state, S4 gallop suggesting more of a stiff, non-compliant heart in the setting of anything that causes a stiff and non-compliant heart, think more of a cardiogenic syncope cause. And if they come in with an EKG that's abnormal with sinus bradycardia, AV to conduction delay, ventricular or supraventricular arrhythmias, long or short QTs, pre-excitation, all these things obviously are going to point towards a cardiogenic syncope cause. There's actually a scoring system you can use if you're in the ER to determine if the likelihood of having cardiogenic syncope is high or low, and also if their mortality at 24 months is high or low. This has been aggressively validated in the Canadian literature called the EGSYS score. I have not used this because by the time they call me, it's more likely to be cardiogenic syncope. So, but if you're evaluating them de novo, you can apply this score. This is through medcalc.com, and they give you more points if the EKG is abnormal. They give you more points if there's palpitations before syncope and syncope with exertion, which all points towards something structural not coming in the way between your heart's cardiac output and your cerebral perfusion. So what do we do when we do suspect cardiogenic syncope? You can do everything: EKGs, echoes, CT angiograms, exercise stress tests, monitors, and EP studies. And you tailor the choice of these modalities based on exactly what you see on the history. So that's what we'll do later today. If you end up suspecting a structural heart abnormality, very commonly valvular heart disease, so aortic stenosis and mitral stenosis being very common. But because this is CPC, I hope this is not severe aortic stenosis, as much as that might be interesting for everyone in the room. It's very bread and butter for cardiology. So hopefully it's more interesting and exciting than that, like maybe a bicuspid aortic valve or maybe a subvalvular or supravalvular stenotic membrane. Hypertrophic obstructive cardiomyopathy is a huge topic. But you can have many different flavors: concentric LVH, asymmetric septal hypertrophy, apical hypertrophy, and all these different phenotypes of hypertrophic obstructive cardiomyopathy can come with obstruction or without obstruction. So paying close attention if they have obstructive physiology or non-obstructive is going to be important for me. Do they have a cardiac mass? Maybe their heart looks completely normal, but they have something pushing into it, like a big lung mass that that my wife would be taking care of. Maybe she referred this patient to me, and there's a huge obstruction into inflow of the blood flow from the venous side, or outflow through an extrinsic mass or an intrinsic mass to the myocardium. Or the heart actual structure is okay, but there's pericardial effusion or pericardial thickening or fibrosis that is mediating impaired ejection or output and cerebral perfusion, causing syncope. If we think that the left side of the heart and the pericardium looks okay, but we suspect increasing pulmonary pressures, then we bring in our pulmonary hypertension hat and think, what is causing pulmonary hypertension? Why is there RV-focused dysfunction? So we could do imaging to investigate for that as well. And then if you think about outside the heart, also the aortic dissections, aortic pathologies can also impact cerebral perfusion, especially if you have an acute aortic syndrome that's causing malperfusion to your end organs, the brain being one of them. And so with that, I would say, the last thing I would say is if you do an ultrasound and you suspect a low ejection fraction, wall motion abnormalities, obviously ischemic heart disease is always on the table. For a 37-year-old, they're diabetic, diet controlled, they have risk factors. We're seeing more and more acute coronary syndromes and coronary mediated pathology in younger and younger patients, and we can go into that in a completely separate topic. But if that's happening, if I suspect a coronary etiology, I'll suspect it based on a low ejection fraction with regional wall motion abnormalities. And then I'll also wonder if that's also tied into arrhythmias of some sort. And so with that, what am I looking for in the EKG? I'm looking for ischemic changes, Q waves, T wave inversions, SE segment changes, bread and butter ischemic changes that we all are familiar with. I'm looking for sinus node dysfunction, AV nodal disease. In a young person, I'm thinking things like Lyme disease. I'm thinking some other genetic syndrome that's predisposing a 37-year-old to have conduction disease. Typically, we see sinus node dysfunction, AV nodal disease in 70 to 80-year-olds, not 37-year-olds. Tachyarrhythmias, that may be both either primary from the heart or secondary to other metabolic derangements. So I'm looking for calcium, magnesium, potassium abnormalities that may predispose someone to electrical arrhythmias. And more importantly, because this is CPC, does that tachycardia syndrome become manifest clinically because they have a structural abnormality? So maybe they would have tolerated their SVT okay, but because they have mitral stenosis or HCM, they're very preload dependent and they lose that compensatory ability, and now they're manifesting as syncope. And the last category here, structural heart disease, LVH, apical HCM. This is just a classic EKG that you should burn into your brain about apical HCM. Deep T-wave inversions in the V4 to V6 leads should just be apical HCM until proven otherwise, especially in a patient presenting with syncope. Oh, sorry, I just highlighted that there for you in case it wasn't obvious. And then the EKG, I told you history and physical and EKG will tell you most of the story. So what I look for in all my outpatients with palpitations, what I look for patients with syncope is evidence of pre-excitation, so a short PR interval, a delta wave, and a wide QRS. That suggests that there's an accessory pathway that's pre-exciting your ventricle and creating that EKG, as you can see in the top right corner over there. More sort of exotic diagnoses, arrhythmogenic cardiomyopathies are a good topic to talk about in a CPC setting. So it's not something I think of immediately when I see someone with syncope, but it's something that I consider in a CPC setting. What you're looking for there are anterior precordial T-wave inversions with an epsilon wave. What causes that epsilon wave? Predominantly V1 and V2. Because the RV is fibrofatally infiltrated, you get delayed activation, delayed action potentials through the RV, and you get this little blip at the end of your QRS, at the end of the RSR prime. And that should be, and with these deep T-wave inversions subsequent to that, that can be a classic look for ARVC. And that's something I'll think about when I look at this patient. If he ends up having no structural heart disease on imaging, I'm looking for channelopathies and primary arrhythmic syndromes. Catecholinergic polymorphic VT is a big mouthful, CPVT. Classically, the teaching is that presents with bidirectional VT. So if I see an EKG during a syncopal event, I see QRS complexes that are wide, that one's pointing up, one's pointing down. Without even mapping it out on an EKG, you can say that's bidirectional VT. There's three major things that cause that, CPVT being one of them. And classically, CPVT occurs with exertion, early in exertion. So you don't have to have a really super fast heart rate on a stress test. It could be in the early phases of a stress test, and you'll see bidirectional VT. The other two things are digoxin toxicity, and then immune checkpoint inhibitors, now that we have a proliferation of immune checkpoint inhibitors for our cancer therapies. Another thing I'm going to be paying close attention to is Brugada pattern on that EKG. What does that mean? That means that if you have a right bundle branch pattern, downsloping SE elevations with T-wave inversions V1 through V3, during a stressor like a fever or a major hemodynamic disturbance, that's when you can elicit the Brugada pattern. The most classic Brugada pattern is this type 1 with these coved SE segment elevations, as you can see. Type 2 and type 3 are more subtle and sometimes missed because they don't look like the exact type 1. But if you see type 2 and type 3 in the right clinical setting and you provoke them with the sodium channel blocker, or if they happen to have a fever the next day and it turns into a type 1, that's diagnostic for Brugada syndrome. And then short or long QT. Oh, I'm sorry. I don't know how that happened. There we go. Short or long QT. So if you're less than 350 milliseconds, we have super narrow QT or really long QT, and there's 3 different types of long QT. That's going to be pro-arrhythmic as well. A short QT just means that the refractory period is super fast, and so you're ready for the next action potential, and that can be very pro-arrhythmic in the right patient cohort population. Long QT is more interesting. So if Akash later tells me that the patient experiences with at the gym or even swimming, the literature for long QT type 1 is that you're swimming and all of a sudden you have an arrest. So if I hear that, then I'm gonna lean on long QT1 until the case is over. But I hope it's more exciting than that. Long QT2, if someone hears a sudden alarm, so if you wake up with the alarm and the patient syncopizes and has an arrest because their alarm went off and it was too high, or the ambulance comes down the road and startles the patient, a startle response associates epidemiologically to long QT2. So if I see a long QT on EKG and that's the history, I'll lean on long QT type 2. And long QT type 3 has a really, really late normal looking T wave. It's just really late. And that one just occurs in sleep, actually. And so that's sort of the epidemiology around that. That was interesting to mention as we learn more about the case. So my initial thoughts, is it obstructive? Is it HCM? Is there a bicuspid valve? Is there rheumatic mitral stenosis? Is there a big cardiac mass? Is there a PE right-sided phenotype versus the left-sided phenotype? For arrhythmias, is there pre-excitation? Is there short or long QT? Is there a Brugada pattern, CPVT, arrhythmogenic cardiomyopathy? And then is this patient taking any drugs that prolong the QT? Maybe there's nothing really wrong with the patient's structural heart, but they're taking meds that prolong the QT. Are there stimulants involved, drugs involved that are implicated? Are there malignant anomalous coronary arteries? So a young patient that comes in, it looks like a STEMI or ischemic insult, maybe just has an anomalous coronary coming from the left or the right that goes right between the aorta and the pulmonary artery that's getting compressed and causing ischemia. Does the patient have risk factors for SCAD? It's usually a younger woman postpartum. This is a man, and so it's less epidemiologically likely, but still something on my mind. And less exciting is it's just myocardial bridging, which means does a major coronary artery dive into the muscle and then dive back out? Is it getting compressed to a point where it's causing ischemia, causing someone to syncopize with some VT arrest? Is the patient hypercoagulable? Do they have a PFO and they're sitting on a hypercoagulable state and they're embolizing small little thrombi causing syncope? Is it infectious inflammatory? A young person is prone to having viral infections. We all went through COVID. COVID myocarditis was this thing. Influenza still causes myocarditis, so does parvovirus. Is there some endocarditic lesion that's causing emboli to the brain, causing some cerebral hyperperfusion? Lyme carditis was the first case that I presented as a fellow. Actually, it was a case presentation to the entire faculty, but I turned into a CPC with our electrophysiologist. I love CPC so much, I brought CPC to Cornell in a format that wasn't even CPC, and everyone actually liked it. And then the next time I tried a Jeopardy and did not go well. And so I went back to case presentations. But Lyme carditis is something that's thought about more in the Northeast, less here in the Missouri Midwest area. But if the patient's been traveling in an endemic area, that's something I think about. You always talk about sarcoid at CPC. It's just always part of the differential. So I'll be looking for evidence of hilar adenopathy, pulmonary infiltrates, erythema nodosum, or classic skin findings like lupus pernio, things like that in the exam features to see if it points me towards an autoimmune vasculitic process. Diabetes is part of the one-liner, so maybe it's relevant, maybe it's not really relevant. If it's a type 1 diabetic, they're probably more prone to atherosclerosis. Maybe they're on some, diet controlled. Maybe they're on some fad diet that is giving them a nutritional deficiency that's making them autonomically unstable, like B12 deficiency and things like that. And so we're all about zebras in CPC. And so what I'll do is I'll talk about the top 3 things I think it'll be. So if there's WPW and HCM, I'm going to lean on Danon cardiomyopathy. If there's no extra cardiac manifestations, there's PRK-AG2 syndrome. Say that really fast. And that's really manifests as HCM and WPW with no extra cardiac manifestations. If the patient has intellectual delay, if they have a muscle myopathy phenotype, I'll think more Danon. But Danon would put together WPW and HCM really nicely. And the more exciting things in aortic stenosis include Schoen's complex. Schoen's complex is when someone's congenitally born with a subaortic membrane, which is an extra membrane that blocks flow out of the LVOT into the aorta, supravalvular ridge above the mitral valve, a parachute mitral valve, which is all the chordae point to one big PAP muscle, and coarctation of the aorta. If any imaging suggests any of that, I'll lean on shown complex. And just because I've been excited about Chagas lately, and sometimes CPC is a curveball, the patient has any sort of exposure to Latin America, or in these days, it's becoming endemic in many parts of the US. So if I see LV apical aneurysms and there's something sexy about the case, I'll think about Chagas myocarditis. I just threw that in there as Chagas myocarditis. And then when in doubt, sarcoid amyloid HLH. I've said it at least once, and so that counts. And what it's not going to be, the last 7 CPCs were these diagnoses, so it's not going to be a cardiac paraganglioma. It won't be AL amyloidosis, and it won't be hemochromatosis. And so that's it.
Okay.
Oh, sorry.
Thank you, Dr. Katchi, for that great introduction and for walking us through how you think about syncope. Clearly, this isn't your first experience with CPC, but hopefully we can still provide you with a bit of a challenge with this case. So going through the history, the patient was in his usual state of health. He was working as a construction project manager. He was at work when he suddenly became dizzy and diaphoretic. His coworkers watched him pass out. He reportedly had a blue face, and they thought he had no pulse. They gave 5 singular chest compressions. He woke up briefly with a little bit of confusion. Then he passed out again. His coworkers gave him another 2 compressions, and he then woke up. There was no AED applied throughout the event. EMS got there. Initial vitals were unremarkable. They checked a blood sugar, which was elevated. They put in some PIVs. They didn't give any medicines, and they brought him to our ED. After arriving in the ED, he did endorse remembering feeling dizzy prior to the event. The only thing he was really complaining about at this time was a little bit of chest soreness near the site of compressions. He says he's never had anything like this before. It sounds like he's reasonably active at baseline. At work, he's able to walk around, able to climb stairs without really any issues. And we can go through the past medical history as well. Really only notable for diabetes, which is controlled with diet. His last A1C was 10.5. He had been working on lifestyle modifications, hadn't been put on any medications yet, no prior surgeries. His father had died of an MI in his 50s. His mother had some sort of congenital heart disease that he didn't know the details of, but said that she never got any surgeries for that. And then he also has a maternal uncle who had an MI in his 50s as well. No allergies, no medicines, going through the social history, never smoker, occasionally drank alcohol, no other drug use, married with 2 kids. And again, he works as a construction project manager. And we can go through the review of systems. It sounds like the team did a pretty comprehensive review of systems and was relatively unremarkable. The patient denied any fevers, chills, weight loss, didn't really have any CV symptoms like chest pain, palpitations, orthopnea, weight gain, lower extremity edema, no abdominal symptoms, no rashes, nothing on the neuro exam, pretty unremarkable review of systems. So initially, are there any other questions about this patient's presentation that I can help you with?
Yeah, let's go back to the history for a second.
Yeah.
And so again, like one slide prior to that. So like we mentioned in the beginning, having a prodrome really opens up the reflex-mediated syncope arc. We're at CPC, so hopefully it'll turn to cardiac. But if someone's dizzy, diaphoretic right before their fall, statistically, you're going to be more likely to be a reflex-mediated syncope for all the reasons that we talked about. I'll be very curious to know what his nutritional status was that day when he was working. Did he have a bunch of coffee with no actual fluids? Did he eat any breakfast? His blood sugar was high enough for this not to be a hypoglycemic event. He had 5 chest compressions and then 2. That doesn't really sound like VT. VT doesn't just stop with 5 chest compressions. Maybe they couldn't find a pulse because they're probably not trained to find a pulse the way you find people are. And then they gave him chest compressions and he woke up. But something caused cerebral hyperperfusion, it sounds like. But it's sounding a little less cardiac to me. It did happen again, which is kind of confusing. But there it was. We don't have an AED, so we don't have strips. His vitals were unremarkable, which is good. He had mental status, which is good. So it sounds like it was brief. It sounds like it fits the definition of syncope. We'll go to the next slide. When he arrives, he remembers feeling dizzy. Chest soreness is not now non-specific because it probably was related to the 7 chest compressions he got. Importantly, he's not getting exertional symptoms prior to this. So if he was having stuttering, angina, or dyspnea on exertion, or something that even resembled something like a coronary issue, I would have expected him to say something to that regard if the history is reliable. And usually for a 37-year-old, it can be pretty reliable. Let's go to the next slide. A diet-controlled A1C of 10.5 is not controlled. So initially, when I was looking at this case, I was thinking maybe diabetes is sort of a red herring. But with an A1C in 10.5, it does suggest chronicity. It does suggest that maybe we should entertain autonomic dysfunction as part of a contributor to this. A father and a maternal uncle dying of an MI or having an MI in their 50s does put me in the category of premature CAD. He has an A1C of 10.5, and he's a man. That's already a risk factor. What we do to suss this out even further in our clinic, and a lot of you guys have come to my clinic, we'll check an LP(a) and ApoB and really lean hard on advanced imaging to identify how much plaque they have, whether that's a calcium score or coronary CT. And so now I'm thinking a little bit, maybe could this be related to something going on with atherosclerosis? But again, with that history, it doesn't scream angina or coronary yet. It's good that he's a never smoker. He's got 2 kids. So eventually genetic screening for this premature CAD history in the family will be important. And the review of systems, I think a lot of important negatives here. And so I listed a lot of things. I took up a lot of your time telling you about all the different things that this could be. And things that I'm now thinking are way less likely, no arthralgias, myalgias, or joint swelling. So I'm not thinking of the systemic inflammatory syndrome that impacts your joints. I'm not thinking of things like sarcoid as much with no rashes. I'm not thinking any multi-system problem that is inherited, such as Fabry's, that can have renal dysfunction, that can have some ocular issues. It can have so this has no hearing or vision changes. You don't really get vision changes, but it's making me think less of some of those exotic other multi-system like glycogen storage, lysosomal storage diseases. I'm thinking it's a little bland of a history, so I'm thinking it's going to be maybe either arrhythmic or something structural that we haven't really figured out yet.
Great.
So on the exam, I'm going to be listening for murmurs, regularity of the heartbeats, and maybe something else on physical exam that wasn't elicited in the review systems.
Okay, perfect. We'll move on to physical exam. The patient's initial vitals were notable for a normal blood pressure 129/88. His heart rate was 108. His respirations were within normal limits. He was breathing fine on room air. He was afebrile. His BMI was 27. He appeared in no acute distress. He did appear a little bit anxious. He had a superficial lip abrasion. His CV exam was notable for tachycardia. The rhythm appeared regular. There were no rubs, murmurs, or gallops. His JVP did not appear elevated. There was no lower extremity edema. His chest wall was a little bit tender to palpation with bruising, and the rest of the exam was unremarkable.
So this is very bland. One thing that you should note, in someone who has cardiac syncope, I mentioned this earlier, they fall suddenly and they get a lot of lip lacerations or fractures of their jaw or their other bones in their body. And if that happens, it's less likely to be reflex mediated and more likely to be cardiogenic because they get no warning. In this case, he had some dizziness and warning, but otherwise this exam is pretty bland. He's a little bit hypertensive, but he probably also had that as a diagnosis that wasn't properly carried over. He's a little tachycardic, so I'm really going to be interested to see what his EKG looks like. And then he's not having any hypoxia to suggest a right-sided pulmonary embolism obstructive phenotype. He's not febrile, so I'm not thinking there's some sort of inflammatory state. And his BMI is not terribly high for someone who has who may have obesity-related diagnoses. So again, I'm not seeing any rashes, nothing on the shins, nothing on the face that would suggest different autoimmune conditions or inflammatory syndromes. So that's actually pretty good. And the fact that he has no murmurs, rubs, or gallops makes the yield on the echo much lower, especially for things like obstructive HCM, for things like a dilated cardiomyopathy with the absence of an S3, a stiff heart with the absence of an S4, and the JVP not being elevated. It makes all these things make me think less things like pericardial diseases. So I'd be looking for a prominent wide descent and things like that. None of that really factors into any of this. So I'm thinking it's probably going to be something primary arrhythmic, and I'm still going to want an EKG and probably an echo, but I'm getting less excited about it as I see the data.
Perfect. Moving on to initial labs. His creatinine was 0.62. Other abnormal labs, his glucose was high at 284. His alk phos was mildly elevated. And then the CBC was most notable for a mild leukocytosis, a white blood cell count of 11.9.
Okay.
With a normal diff.
I'm not terribly excited about any of these things. The alk phos just maybe a little bit above normal, and the white count could be reactive. So it's not changing my differential in my thought process as of yet. Oh, I will say the absence of an abnormal potassium and a magnesium and calcium actually helped me. So if I see a prolonged QT and I see these electrolytes being normal, then I'm thinking of primary long QT syndrome that we've discussed before.
Perfect. So I know you already mentioned this, additional diagnostics, talking about an EKG or echo. Are there any other additional preliminary tests that you would get?
I think for syncope, you do history, physical, and an EKG just at the bare minimum, and then we go from there.
Okay, perfect.
Like I said, I'm flirting with echo because that's what we do, and we're at CPC. But EKG is what I want to see first.
Sounds good. So we have 9 categories here for you. Not all of them are going to be necessarily relevant to the case. The first one is imaging. This is non-cardiac imaging. Infectious evaluation, urine studies, room serologies, additional infectious evaluation, basic cardiology. We can go back to the initial labs if you want to review those, advanced cardiology, and then pathology.
Okay. Seeing that there's no pathologist in the room, I don't think that's going to be relevant. And the advanced cardiologist, I mean, I'm here to read, but there's no radiologist, so I think it's going to be a little bit more simple than that. But I do want to start with what I would do normally in real life. I would get an EKG, so let's start there, and then we can get other labs.
Perfect.
Oh, okay.
All right, so we're starting with the EKG.
All right, so I'm going to just step closer to here. So the way I read this for the med students in the room, rate, rhythm, and access. And so the rate here, if you count the boxes, I pick one of the leads where the QRS complex starts close to the big box. So if you look at lead 3, it's 1, 2, 3, it's a 300, 150, 70. So it's about 70 beats a minute. I see a P wave before every QRS complex. You see very notably a widened QRS with the right bundle branch pattern. You see an RSR prime in V1 and V2. That in a young person can be actually a normal pattern, especially if it's a little bit more narrow than that. An incomplete right bundle branch pattern is not pathologic, but there is what appears to be a wide QRS there. And the T wave, it completes its repolarization somewhat late. I'd have to get out my calipers to see how long that is, but that QT looks a little bit long to me. It's a little bit broad-based. And we talked about long QT 1, 2, and 3. 1 being a broad-based QT prolongation, 2 being a little bit more flat, and 3 being a normal-looking T wave just happens really late. So I'm a little bit concerned about the QT prolongation in lead V1 through V3 in particular. I'm worried about the right bundle branch pattern. When I see a right bundle branch pattern, I talked about earlier that there could be epsilon waves that could be late activation from the right ventricle. And so I'm not seeing an obvious epsilon wave in V1 and V2. And I'm not seeing the T wave inversions that go along with that either. So ARVC is going lower on the list. There are some SC depressions inferiorly. And he's got some strong AVL forces. You see AVL criteria for LVH is met by having an amplitude more than 11 millimeters. The other precordial criteria of an S in V1 and an R in V5, V6 being more than 25 or 35, depending if you're a man or a woman, are not met. But I'm thinking there might be some thickening of the heart just based on AVL criteria alone. So I'm looking at the incomplete right bundle, prolonged QT, especially in V3, and the SC depressions that could be a strain pattern as something that I'm paying close attention to. I'm not seeing an RVH pattern. The axis here, it's positive in 1 and negative in AVF, so it's it's a leftward axis. So other things I have to think about are a left anterior fascicular block when you have a QR complex in 1 in AVL and an RS in the inferior leads. You think about left anterior fascicular block. So I'm thinking about all those things as I look at this EKG. So an abnormal EKG with someone with syncope, again, pushes you towards getting more structural imaging like an echo to start.
Perfect. And some other cardiac tests were obtained. The patient had 3 troponins in the ED, which were all within normal limits. Then they stopped trending them. The NT-proBNP was 203. And then some lipids were obtained, as well as some advanced lipids.
Oh, wow. Okay.
The cardiology resident admitting the patient was a future cardiologist.
Great. So yeah, so I mean, this tells me that whatever amount of hyperperfusion he had to the brain, the myocardium was not insulted to the point where the troponins rose too much. The NT-proBNP does not reflects the lack of excessive stretch in the ventricles and the atria. And the lipid panel is classic lipid panel you see with someone that comes in with diabetes and A1C of 10.5. Interestingly, is LPA and ApoB. LPA is an acute phase reactant as well. So if someone comes in with a URI and you're checking an LPA, it might be very elevated. So the fact that it's not elevated is my surrogate ESR CRP for the moment. But interestingly enough, it's not elevated in spite of his family history. His ApoB is elevated, which means that the LDL that he has is more atherogenic than someone whose ApoB content is low. So if I was seeing this patient in the outpatient setting, I'd be very aggressive with that LDL, more so than I would be just with someone with diabetes.
Perfect. So at this step, there's a lot of different non-invasive tests we have to evaluate the heart. What kind of tests would you pursue first?
I would start with the echo.
Okay.
Yeah.
That is the next step. And the echo was done. It was read as normal LV size, LVF of 62%, normal RV function, no significant valvular disease, normal RA pressure, and normal diastolic function. So a very unremarkable echo.
Yeah. So when you have an unremarkable echo, all the structural things I told you about, HCM, ARVC, all the other things, shown complex with subvalvular stenosis and a mitral ring, all that's out the window. Other things that can be pro-arrhythmic in the heart could be mitral annular disjunction when you have mitral valve prolapse. That wasn't present either. So now I'm thinking very heavily towards channelopathies, long QT syndromes, maybe even Brugada patterns and things like that. But I didn't see a classic Brugada pattern in that EKG. I'm thinking more now with that long QT being a contributing factor.
Okay, perfect. So now that you're suspecting something like long QT, what kind of test would you pursue next to evaluate this further?
Well, then I would call my EP colleagues to see if I'm crazy or not, and when I'm purporting. But more importantly, I know we said he was just on diet-controlled diabetes. Was he taking anything over the counter that would be QT prolonging, some online supplement that would be QT prolonging? His electrolytes were not a confounding variable. We talked about that as a pertinent negative in his labs. But now I'm really wanting to flush out this potential long QT syndrome. So if I was seeing this patient that came in with the syncopal episode, I would definitely watch him on a monitor to see if he's pro-arrhythmic. Obviously, avoid long QT prolonging agents. And if I had to send him home, if he was stable, I would send him home with a cardiac monitor with plans to do genetic testing and referring to my EP colleagues and potentially even doing an EP study if there's some gray area in the diagnosis.
Okay, perfect. So just to give you some background, the patient was admitted for observation on telemetry. They didn't see any abnormal rhythms initially. They did get some imaging in the ED, which I can show you.
Okay.
The chest X-ray was unremarkable. The CT head didn't show anything. They scanned his head to see this syncopal episode. And then they obtained a CTA, chest, abdomen, pelvis, to look for things like a PE or a dissection. It was pretty unremarkable, except it did show some mild coronary artery calcifications.
Okay. So yeah, one thing, in the absence of a structural abnormality in the baseline echo, you still have to entertain anomalous coronaries. And in this gentleman, he's diabetic with an A1C 10.5. You could have atherosclerosis that isn't picked up by calcium. You could have soft plaque that's causing significant issues. The reason I moved away from that is because the troponins were so normal and there was no ischemic changes on the EKG. So that made the idea of this being an ischemic until lower in my mind. But you can always entertain anomalous coronaries that will be intermittently compressed depending on what's going on. And so in cases like this where we don't get a final diagnosis, and maybe I call my EP colleagues and they're not as excited about the long QT as I was, I would want to define coronary anatomy in a young patient, even if the case doesn't automatically scream coronary ischemia. So just to define whether he has a high-risk coronary anatomy.
Okay, and how would you do that?
Well, if you're asking me, I would do a coronary CTA because that's what I am a co-director of. But you could do a cardiac catheterization like 20 years ago. You could do that and that'd be appropriate. But a CT nowadays will get you the answers you want in complete diagnostic terms. And you'd be able to tell it not only where the artery is going, but are they taking an anomalous course? I could tell you if there's a slit-like orifice. I could tell you if there's an acute angle takeoff. And I could help plan whatever is needed with just the CT data set to start. And it's non-invasive. It takes 5 minutes. It's much easier.
All right, perfect. So now we're moving on to advanced cardiology. And
okay.
I have some pictures here for you.
I'm waiting for that RCA to keep going. Okay. So what you have on the left-hand side is just your axis to run from cephalad to caudal. On the right-hand side, you have what's called curved multiplanar reconstructions. So what our software can do is it can track the contrast load. It can track the entire, what it calls a center line through what it thinks is a LAD, an RCA, and a circumflex. And then it can stack all those images together and give you a multiplanar reconstruction. Then you can spin it out like a noodle. And so in the, I assume the way you've presented this one on the left, this first one, is probably the RCA. Is that right?
I think so.
And in the middle one looks like the left anterior descending artery, and the right one looks like a diminutive circumflex artery. And what you can see already in the reconstruction, which is easier to see, in the middle of that RCA, there's a calcific nodule. Now, depending on the scanner used, we can quibble about how exactly stenotic that particular lesion is, but that looks somewhat concerning, especially in someone who's presenting with a syncopal episode. Now, it doesn't really match what we're talking about with his troponins, with his EKG, and his presentation, but that is a coronary finding that is of concern in terms of adjudicating whether it's ischemic or not. The LAD has calcium and atherosclerosis caked throughout the vessel, but nothing seems obstructed in that sense. In the left-hand side, the circumflex looks like it's a small vessel that has some atherosclerosis, but nothing slam dunk that's obvious in terms of severe. There's some mixed plaque in that mid-circumflex, but it's a small vessel and it should not be related to the syncopal presentation. Now, a couple things on the CT. You can see opacification beyond what appears to be a blockage because of collateral flow. So if you have ample collateral flow from a chronically occluded vessel, you'll see it light up the way it does here. And so you can't fully be, I can't really make that call just based on one curved NPR. I'd have to get a short axis representation of that RCA. But that is a concerning lesion. What's important here, if you look at the axes that are going down, there's no anomalous coronary artery. The right coronary comes from the right coronary cusp, the left comes from the left coronary cusp, and there's no apparent myocardial bridging. That should be a culprit here. So I'm not seeing that this is the exact answer, but this is something that I would have been interested to see with this presentation.
Perfect. Yeah, I know you're limited by the photos that I gave you, but how this was read is that the patient had calcified and non-calcified plaques up to moderate stenoses in all three vessels.
Okay.
So multi-vessel CAD with a calcium score of 470.
Got it.
And so what are your next steps, knowing that this patient has some CAD, maybe chronic in nature with the negative troponins and no EKG changes? How do you make sense of this?
So all the things I told you about anomalous cores and premature atherosclerosis, he has premature atherosclerosis, but I don't think it's leading to a syncopal event. So now I'm going back to that QT that's prolonged, and I'm focusing more attention on the arrhythmic channelopathy side of things.
Okay, sounds good. So what test would you want to do next?
So there's genetic testing you can do for long QT syndrome. That won't come back for probably a couple of weeks. I definitely still am leaning towards having him, either have stay monitored with telemetry or being sent home with an event monitor, and then following up with their EP colleagues to see if he needs an ICD for prevention or not. Especially if he has multiple arrhythmic events on that monitor.
Given that the echo is normal, is there any other structural kind of tests that you would consider doing?
Well, I didn't get to see the images in the echo to see what the quality is like, but if I had some lingering suspicion that there's something that was missed in terms of myocardial deposition, myocardial infiltration syndrome, then I would think about a cardiac MRI, and then we bring back in some of those rare diagnoses that we were talking about, the infiltrative cardiomyopathies like sarcoid or amyloid in the right patient. Nothing of this case has pushed me in that direction, except for maybe sarcoid that can be a mimicker and can have some conduction abnormalities, which we saw in the EKG. And so if I, on the CT, saw hilar adenopathy, if I saw pulmonary nodules, and if I saw things on exam that pointed me towards sarcoid, I would have mentioned that. If on the echo I had seen basal infralateral wall, septal wall abnormalities, or maybe small little aneurysms, I would have thought more sarcoid, but nothing here is screaming sarcoid from a cardiac standpoint just yet.
All right. Well, the patient was admitted to cardiology firm, and they did obtain a cardiac MRI. So
I'm sure they did.
I can show you the pictures.
Okay, so in the top left, you have a 4-chamber view, and it looks like the LV function looks preserved. The left and right look fine. We go to the second one. Are they supposed to all play at the same time? Okay. I'm also looking for there being any masses or anything like that that could explain intermittent obstruction. With the normal echo, you wouldn't expect to see something, but sometimes the MRI can show you things that the echo did not.
These two on the right are stills.
Oh, they're stills. Okay, so yeah. The left-hand one, I don't see any tricuspid regurgitation. The myocardium looks okay. There's some suggestion of some septal hypertrophy right there. And so the still frames on the other side don't look actually that hypertrophied. You see that little bulge of the septum. Sometimes in some patients that have asymmetric septal hypertrophy, you have to measure that and make sure it's not more than 15 millimeters for an HCM phenotype. But nothing screams out at me abnormal from the cine images. And the second one that you're showing me is looking more at the interatrial septum. I don't see any defect there. I don't see any atrial pathology. And then the scar on the right. So the top right image is late gadolinium enhancement. As you can see on the top right corner, you see a little gray fluffiness in the anterolateral wall. That's not normal. And someone who has normal function there, but some infiltration there, now you're thinking more basal anterolateral wall scar and what's causing that. So you want to see if it's subendocardial for an ischemic insult, mid-myocardial for some dilated secondary myocardial process, or if it's epicardial, which is more inflammatory, myocarditis, sarcoid, and things like that. This sort of focal, patchy, mid-anterolateral wall scar is something to be paying attention to, and could be definitely implicated in his presentation, and would raise the stakes for him needing some sort of ICD or any further evaluation for what's causing, one, the infiltration, and two, the arrhythmia that may be associated with it. And the bottom two, are they supposed to be?
So this one on the bottom right is a still. I can play this.
Okay. That's at the basal level of the mitral valve. Not super, super helpful. I don't see any focal wall motion abnormalities. And then the last one is probably just another post-contrast image that looks at scar in the same distribution. So it's right over that anterolateral pat muscle. So it's over the anterior anterolateral wall segment. It looks more mid-myocardial to me. So that could be sarcoid can present in very classic ways, basal interceptum, inferolateral, but it can present in many different ways, one of which could be this way too. Was there anything extracardiac that was mentioned on the MRI or the CT? Okay.
Nope. And I can tell you how this cardiac MRI was officially read: normal biventricular size and function. And then there was this focal delayed gadolinium enhancement within the anterior and anterolateral wall at the mid cavity, favored to represent a scar given normal wall motion.
Yeah.
And it sounds like at this point, the team took a very detailed history. And the patient said, oh, maybe I've been having some chest pain after meals. The team thought, maybe it sounds like GERD, but it sounds like it's new over the past month. How would you proceed?
Yeah, so I mentioned sarcoid and how not many other things in this history fit this. This distribution over an anterolateral distribution also makes you invoke a vascular territory. And someone that doesn't have any obstructive coronary disease on the CTA and the LAD territory, you have to think about SCAD. I know that this isn't the classic presentation for SCAD for a postpartum woman in their 30s or 40s, but in this patient who maybe had severe vasospasm or maybe had a thrombus that occluded the LAD that then recanalized by the time you got those 7 chest compressions, this would be a good look for an ischemic insult over that territory that then recovered because you didn't have that much downtime. And so if I was worried about SCAD, CT isn't the best for that because, again, the SCAD lesion can recanalize and reheal. And so it's more of an angiographic and clinical diagnosis if it fits with that. And as we're invoking those things, sometimes you think about other things like FMD, and you think about small to medium vessel vasculitis that can go with that. But again, nothing in this story screams those other things. There wasn't excessively tortuous beads on a string pattern for FMD. So I'm thinking maybe it's atherosclerotic that recanalized, or maybe there's SCAD involved with this sort of MRI finding.
Okay, perfect. So what test would you do next?
So in this case, it would be a tough decision because we have coronary anatomy. And likely, if you got a cath at this point, you'll see a recanalized open vessel. But I guess you could consider looking at that LAD territory one more time to see if you missed a diagonal branch that maybe isn't well characterized on the CT scan. The CT scan quality wasn't the best. And so if you want to be definitive, you could go back to the cath. I hesitate as I say that because the treatment for SCAD isn't just watchful waiting and antiplatelet therapy. So what are you going to do with the cath other than form a diagnosis? And if that doesn't help, and if you still think there may be some cardiac sarcoidosis with the conduction abnormalities that we saw, you could do a PET to look for sarcoid, or you could do a cardiac catheterization, depending on which way you're leaning. In this case, I probably would lean for a cath.
Okay, perfect. So that was the next step done. All right, and I have some more pictures for you here.
Okay, in the top left image there, you're seeing the circumflex, and I don't see any acute lesions there. You're kind of getting a glimpse of the LAD system. If you play the second, that's the right coronary artery that looks totally fine. I told you it was diminutive on the CT. It clearly is not diminutive. If you go here on the bottom left image, you see that they're wiring the left circumflex either to treat what they think is two sequential lesions, and that what appears to be an obtuse marginal, or they're doing IFR assessment of that lesion. And then the last image looks like they probably already fixed it because it looks far more open. The wire's still in there. Okay. Did they do an intervention here?
They did do an intervention.
Okay. Yeah.
They did place a stent in the left circumflex. There was a distal circumflex lesion that was about 90% blockage, they estimated.
Okay.
So do you think that those findings on the cardiac cath correlate with the patient's initial presentation? Do you think we fixed everything?
It's a little awkward for us because the circumflex going to the OM would feed more the lateral territory. The lesion that we saw in the MRI was more anterolateral. He had no troponins, so it would be very odd for this lesion to be fully explaining everything that was going on. I'd still want to explore that long QT, the relatively long QT that we saw as a bystander other diagnosis, but I don't think this fully explains everything that we just saw on the MRI and in this clinical case.
Okay, sounds good. Well, after this PCI, the team was actually planning on discharging the patient the next day until later that night when this was noted on his telemetry.
So it looks like his AV node stopped conducting. He probably was started on a lot of metoprolol for his coronary disease, and who knows what was happening as he was getting up in the morning, but he seems to have no conduction down his AV node transiently, and I hope someone got to him.
Someone did. So this lasted for 30 seconds. He felt very dizzy and nauseous. He said this is exactly how he felt prior to his syncopal episode at work. He was promptly transferred to the CCU. They considered putting in a TVP, but he went back into sinus rhythm, so they didn't ultimately put in a TVP, but they monitored him in the CCU.
So right bundle branch block, AV block with that scar pattern on the MRI now is pointing me very heavily towards a cardiac predominant sarcoidosis. Assuming this wasn't all medication related and he wasn't bageling and having a coughing or defecation event while he's on telemetry, I'm very concerned about conduction disease now.
Okay, sounds good. So what tests would you get?
Well, in this case, I would probably get a FDG PET to make sure that he doesn't have any sort of inflammatory issues around the AV node.
Okay, perfect.
Or the scar that we saw in the MRI doesn't correlate with the hot take.
So we can start with the image in the top left here.
Okay. So if you play the merged one in the top right and just pause it on the heart, I'll tell you when to pause it. Pause it right there. So here you see, it's pretty obvious. You see it's lit up where the septum is, and it's lit up on the in the anterolateral wall. These are classic. This is a classic look for cardiac sarcoidosis. The inflammation around the septum is probably mediating where he's having AV nodal conduction abnormalities, and the lateral wall corresponds very nicely to what you saw in the MRI. And so with these markers and the entire presentation you've shown me, I would say this is cardiac predominant sarcoidosis.
Okay, perfect. And how would you proceed next if you were the attack?
Well, I talked to Adam Anderson, and I'd get him started on immune modulating therapies, either in-house, actually, yeah, probably inpatient, to make sure that we don't miss this because he seems pretty inflamed at the moment. And with the amount of scar that you saw on that MRI, you probably need to talk to EP about putting in a defibrillator because he came in with syncope. He's having a AV nodal disease, and he probably had some sort of electrical arrhythmia with that lateral wall inflammatory state. So those are all things that are running through your head, not discharging him that day, keeping him a little longer, and doing all those steps. Okay.
And do you think about a biopsy in these patients?
You could if the diagnosis wasn't super clear. Again, this is inflammation. This isn't a tracer that's specific for sarcoidosis. You could do a biopsy to look for the non-caseating granulomas that you would expect to see, and then have a definitive diagnosis that way. But if you only gave me this, I would start empiric treatment without the biopsy.
Okay.
Yeah.
Perfect. All right. So we're almost ready for final thoughts. Any last thoughts?
That's it. I think it's sarcoidosis. Yeah.
Okay. All right. Perfect. Great job.
There's no biopsy. They didn't do a biopsy.
The team did do a biopsy.
Oh, they did?
Yeah.
Okay.
So the team ultimately did decide to do a biopsy. They pursued endomyocardial biopsy. The pathology was positive for non-caseating granulomas. Going through the patient's hospital course, the patient did have a dual chamber ICD placed because of his complete heart block and risk of sudden cardiac death. Rheumatology was consulted. The patient was started on steroids and methotrexate. He was ultimately discharged with outpatient EP and rheumatology follow-up, and he still follows here at WashU and has been doing great. No further hospitalizations. And just a couple of teaching points about sarcoid. It's an inflammatory disease with unknown etiology characterized by non-caseating granulomas on pathology. There is an association with certain genetic and environmental factors such as beryllium or dust exposure. It was thought that in this particular case, the patient's exposure to dust as a construction worker may have predisposed him to getting the sarcoidosis. The presentation can be very heterogeneous. Most patients have some sort of lung involvement, so this can be in the form of hilar lymphadenopathy on imaging or dry cough or dyspnea as far as symptoms go. 25% of patients have some sort of heart involvement, so that usually presents as conduction abnormalities or ventricular arrhythmias like ventricular tachycardia, or they can have some sort of cardiomyopathy. 25% of patients have some sort of skin involvement, so this is a rash on the shins called erythema nodosum or some rash on the face called lupus pernio. 50% of patients have some sort of ocular involvement in form of uveitis or dry eyes, and then many patients also have constitutional symptoms such as fatigue, weight loss, low-grade fevers, and malaise. And the treatment is immunosuppression. Typically in the acute phase, people are placed on high-dose steroids, and then they're slowly weaned off steroids over the course of the next several months. I believe this patient was on steroids for about 9 months, and then the goal is to get them on some sort of steroid-sparing immunosuppression eventually, like methotrexate. And then some points about cardiac sarcoid specifically. The AHA published guidelines about the diagnosis and management of sarcoid last year in Circulation. It can be difficult to diagnose, but in general, when you should suspect it in a patient who does not have a known history of sarcoid is when you have young patients such as this one under the age of 60 who have some sort of high degree AV block or unexplained ventricular arrhythmias. And usually the first imaging test to obtain is a cardiac MRI, but if you have a high clinical suspicion for sarcoid, even if that's normal, you should then pursue the PET scan. And the PET scan can also be helpful because you can see other organs that are involved by sarcoid and maybe easier targets to biopsy. Because endomyocardial biopsy does not have a high sensitivity for detecting sarcoid, even with image guidance. With image guidance, it's still around 50% sensitivity for diagnosing sarcoid. And other things to note, even with treatment of sarcoid, the conduction abnormalities are not consistently reversible. So a lot of times these people will need some sort of device. This is as opposed to something like Lyme disease, where if you treat them promptly with antibiotics, their conduction abnormalities a lot of times resolve and they don't need a device. And there is a class 2 recommendation for patients with cardiac sarcoid who are already getting a device because of conduction issues that they should also get a defibrillator because there is an increased risk of ventricular arrhythmias and sudden cardiac death. And that's all I got. Thank you, doctor.
Thanks, George.
Great. Oh, great. It's okay.